Hi everyone, I'm going to talk about how to navigate through different hybrid applicator for gynecological brachytherapy. As we all know that use of hybrid applicator is going up because of better therapeutic ratio, and there are a spectrum of hybrid applicator available. I'll discuss some of these applicator which are available with Bravos and Variant technology to discuss the uses of this applicator, the pros and cons of the approach, and some practical tips. So we know that the dosimetry has changed significantly for cervical cancer. If you look at ABS 2012 guideline, it said D90 to HRCT between 80 to 90 gray. But now Embrace 2, which recently reported their studies, aim for D90 of 90 gray with a lower limit of 85 gray. It also had other factors or dosimetric factors available, like if you contour GTV, a D98 of GTV of 98 and above, with keeping 0.8 dose to 65 and above. Similarly, the organ at risk doses have also changed significantly, like from ABS 2012 guideline of keeping rectum to less than 75, sigmoid to less than 75, bladder to less than 90 for 2 cc dose. Now in Embrace 2, based on some of the available outcome data, the aim was to keep 2 cc less than 65 gray for rectum, 2 cc less than 70 gray for sigmoid, and 2 cc less than 80 gray for bladder. Besides that, for vaginal toxicity, the rectovaginal point was defined to keep below 65 gray, and ICRU bladder point was defined to keep it below 75 gray. So you can see over a period of time, the doses to target have gone up and the doses to organ risk have gone down to improve therapeutic ratio. But to keep these doses, it is important that the advanced applicator are used. And based on this Embrace 2 study, which was recently presented at Astro, I'll show you the data, more and more people are going to use hybrid applicator to improve therapeutic ratio. Like the Embrace 2 data was presented at Astro by Dr. Potter. It is a single arm phase 2 prospective study using advanced IMRT, IGRT for external beam with SIB boost, and also adaptive brachytherapy using MR-based brachytherapy with decreased dose to rectum, bladder, bowel, and vagina, which I showed previously. They recruited about 1,450 patients from 49 centers worldwide. And if you look at it, when they reported the results, there was significant improvement in local control with a 3-year local control of 93%, the nodal control of 95%, and distant control beyond periodic nodal control of 88%. Similarly, the overall survival at 3 and 5 years was 87 and 82%. But more important, look at grade 3 morbidity. The grade 3 to 5 urinary, GI, and vaginal morbidity was 8.9%. In contrast to Embrace 1, where these grade 3 morbidities were significantly higher, reaching between 25 to 30%. So the conclusion from this study was substantial improvement in therapeutic window in comparison to Embrace 1, with risk reduction of disease progression by 70%, risk reduction of death by 2%, but most importantly, risk reduction of grade 3 to 5 morbidity by 45%. And basically, this established MR-based brachytherapy as a standard of care. And important to understand that 74% of the cases in Embrace 2 used hybrid applicator to improve this therapeutic ratio, to achieve high dose to the target and reduce dose to the organ risk. So in this talk, I will talk about some of the hybrid applicator and give some practical guidance. So these are the hybrid applicator I'm going to cover. The first one is an Aarhus applicator. It has got a tandem and a ring, but there is no ring channel. It has straight and oblique needles to cover both medial and lateral parametrial disease. The second applicator is the tandem ovoid, which has both straight and oblique needles with guide tube to help placement of the needles. So the third one is the interstitial cylinder. Interstitial cylinder has got multi-channel in the cylinder, but the important thing is the needle from the tip from the interstitial cylinder can go into the cervix, and it can be combined with Kelowna template. And the fourth one is multi-channel cylinder with Kelowna template. The difference between multi-channel and interstitial cylinder is in interstitial cylinder, the needle can go through the tip into the cervix, while on multi-channel, they end at the tip. So when you're using one of these two applicators, you have to be careful in what you want to cover and how do you want to use it. So hybrid applicator for brachytherapy, like let's talk about the Aarhus applicator. So Aarhus applicator, as we all know that when that main advantage, one of the main advantages of hybrid applicator, you don't need to go to perineal tissue. You can get your desired results through transvaginal route, which makes it easier on the patient. You can achieve the goal with less needle and less penetration. And the small ring of the Aarhus helps you with insertion. Like the cases I have done, the smaller ring of the Aarhus helps you in patients with smaller anatomy. It has got both straight and oblique needles, so you can pick up the needle position based on the pre-brachytherapy MRI. But one important aspect I want to highlight, it doesn't have a ring channel. So if you're using this applicator, you have to use needle on both sides to supplement the dose distribution like ring also. The one way to get around with this, the standard ring and tandem, which is of the same size as Aarhus applicator, can be used if you're not planning to use the needle. But if you're planning to use the Aarhus applicator, you have to always use the needle. It has, as I said, it has got both straight and oblique needle. The outer one is the straight, the inner one is the oblique. You can see how the needle, the hole placement works out to be. Most of the time you place the needle laterally to replicate the distribution of the ring. And then you can see this is the straight needle and this is the oblique needle, which helps you cover medial parametrium and lateral parametrium. Now this is the hybrid applicator for people who are used to tandem and ovoid. It does a similar job as Aarhus applicator, just the fact that some people are more used to tandem and ovoid, so they prefer that. Again, it is versatile and flexible. It has also got both straight and oblique needles. It is MR compatible. There is thin tandem. Like if you feel this tandem is thick, you can use the needle tandem also in some people where it's harder to place the thick tandem. As I said, it's got parallel and straight needle. It has got rectal retractor, and the basically the guide tube helps you better control the needle placement because you can control the depth from the outside and insert based on desired depth, and you can mark the patient here to push the desired depth. So it's a similar concept as ring applicator with needle, but for people who are used to the ovoid, this may be the preferred way to do it. It's not, it is individual preference. I favor ring applicator, so I tend to favor Aarhus, but some people may like tandem and ovoid, so they may favor this applicator. Now this is the third one. Like you can see, this is the interstitial cylinder, and you can see the needles go out. There are oblique. Basically, this is how the oblique needle comes out from the interstitial cylinder, and this is multi-channel. You can see there is no needle coming out of it. So both these applicator can be combined with the tandem. So you can do tandem with interstitial cylinder like this, where the needles come out obliquely, so you can help cover the cervix and parametrium. And the advantage is because you're using the cylinder, you can extend the isodose line inferiorly. So it helps you cover the disease in the vagina, which sometimes could be a factor for ring and the ovoid, because the coverage of the ring or ovoid is for the few centimeters in the vagina. If it is more than that, this helps you out. Both this applicator can be combined with Kelowna template. So if you want to go more lateral or add more needles, you can use template. But when you use the template, then you're going to perineum. So this part of the applicator is through the vagina, but this part of the applicator goes to perineum, like any other template-based brachytherapy. So it's a versatile applicator. You can do tandem and interstitial cylinder alone. You can do tandem and multi-channel, or you combine tandem and multi-channel with Kelowna template to add to your flexibility. So the general guidance is a single intrauterine tandem provides adequate dose coverage for approximately 2 centimeter tissue on either side of the uterine canal. So it can change based on anatomy, but about 4 centimeter of symmetric disease. If you add one row of straight needle, you can further extend the coverage by additional 1 centimeter. So you can go up to 3 centimeter from the midline based on the number of needles, weighting and dwell position using the needles, and the symmetry or the configuration of the tumor. On top of that, if you incorporate additional oblique needle, you can go add another 10 millimeter. So you can go up to 4 centimeter from the midline based on, again, location of the tumor, number of needle, and dwell position of the weighting. These are not fixed rule, but this will give you the guidance. So if it is up to 4 centimeter, you can cover with tandem. More than 4 centimeter, up to 4 to 6, you can make cover with single a straight row needle. But if you have to go beyond that, you have to do oblique needle. The insertion depth of the needle is usually between 2 to 4 centimeters above the surface of the ring of the ovoid, based on the length of the cervical canal and vertical dimension, which you can see on the imaging. So normally I go up to 3 centimeters, but sometimes it could be more or less. But when I'm pushing oblique needle, I'm a bit more careful because oblique needle, when they go beyond cervix, can be close to parametrial vessel. The straight needle usually tend to be in the cervix or the uterus to have more safety, but oblique needle could be closer to parametrial vessel. So I'm very close to it because of potential risk of vascular injury. I tend to sometimes under push it and adjust on the CT scan. So my workflow is, if I do the placement under ultrasound guidance, I'm at the time of the CT scan, I may adjust the oblique needle a bit more if I'm not sure about it at the time of the placement. So this is example of Aarhus vaginal template with straight needle. You can see the disease is around 4.5 centimeters or so. And so what we did was we put the tandem and we put the Aarhus template, the smaller Aarhus template. We use these row of the needle, the lateral ones, and only the straight ones. So the inner one are straight, the outer one are straight, the inner one are oblique. You can see the two needles placed on either side, and which helps you cover the disease. You can see the depth of insertion is maybe around 2.5 centimeters going up to the cervix. So this is uterus, this is cervix, so depth of insertion is into the cervix. You can see straight needle, even if you push more, it still remains within the cervix or the uterus. Now you can see by these are the clinical goal, you are able to achieve your so-called embrace dosimetry guideline with a D90 of 85 to 90 and above, D98 of 95 and above, and D2C bladder, rectum, and sigmoid of 65 for the rectum, 70 for the sigmoid, and 80 for the bladder. Now, if I'll show you the insertion of this applicator.